Welcome, everyone. I'd like to welcome our donors who make the advancements in care, wellness, and research possible every day. Your monthly gifts, legacy contributions, and donations to support important care and innovation is what makes it possible for us to push healthcare boundaries. I'd also like to welcome our board members, Alberta Health Services partners who relentlessly strive for the best healthcare in our community with the commitment to you and your loved ones who deserve nothing less. I am your host, Mike Meldrum, President and CEO of the Calgary Health Foundation. And on behalf of our team, it is our pleasure to host you this afternoon. 80% of Albertans depend on our health system each and every year. Let that sink in. 80% of all Albertans. Eventually, and sometimes unexpectedly, every one of us will seek urgent medical care. And when we do, we all want the best possible health outcomes for ourselves and our loved ones. Heart disease is the second leading cause of death in Canada and affects over 2.4 million adults. In Southern Alberta, that equates to 1 in 2 people that will require cardiac care or cardiac diagnostic imaging in their lifetime. Perhaps you know someone or you yourself have had an experience. The great news is that we all live in Alberta and have some of the best clinicians and researchers in our corner. Today, we are pleased to highlight a leader and innovator in cardiac care that not only Southern Albertans are benefiting from today, but is informing care across the world. The Stephenson Cardiac Imaging Centre, led by Dr. James White. This center is an example of the power of partnership and integration, located at the Foothills Medical Center, with a dedicated MR machine also at South Health Campus. The clinic is operated by Alberta Health Services, who provides care to patients every day. Yet through a unique partnership here in Calgary with the Libin Institute at the University of Calgary's Cummings School of Medicine, research is integrated into daily clinical practice to inform and innovate cardiac care for more than 15 years now. Today, you'll hear from 2 people that will show the impact of your support and care being offered today and care into the future. First, you'll hear from Dr. James White, who is a clinician scientist, cardiologist, and director of the Stephenson Cardiac Imaging Centre. He is a Peak Scholar and professor of medicine in the Department of Cardiac Sciences and Diagnostic Imaging, and is also the chair of the Libin Data Initiative at the University of Calgary Cummings School of Medicine. Dr. White leads an expanding translational and clinical research program named the Personalized Diagnostics Program, focused on the development and validation of innovative approaches to achieving personalized medicine and clinical practice. His research applies machine learning-based techniques to large population health and diagnostic test repositories to achieve automated diagnosis and personalized risk prediction modeling. He is a leader, innovator, and champion of advanced care for Albertans through a progressive partnership between Alberta Health Services and the Cummings School of Medicine. Next, you'll hear from Joe Horler. Joe is an avid photographer, a lifelong learner, and this summer underwent an unexpected cardiac double bypass surgery. He was treated at the Foothills Medical Center, and as you will hear from Joe, the care he received was exceptional. Joe will share his experience with us, what he learned, and why he's chosen to make a donation in gratitude for the exceptional care he received. But before we start, just wanted to go over a couple of housekeeping items. Following Dr. White's presentation, and after hearing from Joe, we'll have a Q&A session. So please use the live chat tool at the bottom of your screen to capture any questions you might have. The event will be recorded, and we'll send you a link to that shortly after the event. If you have any questions or are experiencing any technical difficulties, we have Valerie Ball acting as our moderator, so please feel free to use the chat box to ask her for help. So without further ado, I'd like to introduce Dr. James White.
There we go, unmute. Thank you, everybody. It's a sincere pleasure to be here and to talk to you all today. And on behalf of cardiac sciences and the entire Stephenson team, I'd like to provide my deepest appreciation for all the support that all of you and the Calgary Health Foundation has provided to the cardiovascular care in Calgary. Today, I'm going to be talking to you about personalized diagnostics and cardiovascular care and share some of the exciting work that we're doing at the Stephenson Centre. So we are actually incredibly fortunate in Calgary to have the Stephenson Cardiac Imaging Centre. It's one of the world's largest and most active cardiac MRI services provided through 2 dedicated facilities at the Foothills and South Health Campus. To date, we've performed over 50,000 scans on over 40,000 unique patients in Alberta. Uniquely, we've been able to integrate a translational research program to deliver leading innovations to our patients. And this has been supported by the CIROC Registry, an initiative seeded in 2015 by a $1 million funding donation provided through the Calgary Health Foundation. This registry now delivers data resources that are used not only by my research program, but by others across Alberta and actually internationally. And my program, called the Personalized Diagnostics Program, is focused on delivering tools for personalized care. The field of medicine has undergone a massive transformation and continues to do so, from a population-based medicine over to personalized medicine. So what do we mean by this? Well, only 20 years ago, we really believed that optimal care could be delivered by applying the results of large clinical trials that were performed in very well-defined patient populations and combining these results into clinical practice guidelines of how we should treat patients with different diseases. However, it became apparent that individual patients don't always fit the mold of an average clinical trial patient. In fact, they often have very many unique features that alters how disease is affecting them and how they'll respond to treatments. By treating all patients according to a generic set of guidelines, we start to realize that there's a lot of variability out there in outcomes. And unfortunately, we're spending a lot of money without getting optimal results. So how do we contextualize care decisions to an individual patient so that the care is tailored to achieve optimal results with the least amount of intervention and cost? Well, we don't have a crystal ball to predict the future, but we have something else, and that's data. If we can capture relevant health information about individual patients, lots of patients, we can start to identify patterns in data that tell us what's most likely going to happen. We call this personalized medicine. This doesn't mean abandoning our clinical practice guidelines or trial data. On the contrary, it means contextualizing that information to an individual patient to improve the care that we deliver at lower cost and with more efficiency and better outcomes. So now, to predict what care is best for an individual patient, we need a lot of information. And the more we know about the patient and the disease, the better we can make predictions. What is the environment that a patient lives in? What are the genetics that that patient holds that might influence how they respond to a disease or a set of treatments? And how much can we learn about an individual patient's disease and its activity? For example, we do laboratory testing to measure things like proteins in the bloodstream that tell us how active a disease is. The area that I have greatest interest in is the wealth of information that we can gather about the disease itself and describe how it looks, something that we call its phenotype. So disease phenotyping in cardiovascular disease is typically performed using imaging. And there's 4 dominant types of cardiac imaging that we offer at Alberta Health Services, and the same across all major institutions. We have echocardiography, which is ultrasound, nuclear and CT imaging, which is really heavily focused on coronary disease. And if we find coronary disease, we often use cardiac catheterization, an invasive form of imaging. But that leaves cardiac MRI, which is what I focus my research in. And there's reasons that we focus on it. First, it's not invasive, there's no radiation, it has superior accuracy, but it's incredibly versatile. And all in, it's actually an intermediate cost test. It's not high like some people believe it to be. And so let's explore some of its most common uses. First, once inside an MRI scanner, we can use it to assess the size, shape, and function of the heart's chambers and the large blood vessels. As shown by the cartoon on the left, the heart has 4 chambers, 4 valves, and pushes blood to the largest blood supply in the body, the aorta. Each of these structures can be elegantly imaged and measured using cardiac MRI. In the middle of the screen, you see a beating heart image from a 28-year-old that unfortunately has developed a very enlarged and weak heart due to a viral infection. We see that there's also some leaking of the main valve inside the left side of the heart, which is called the mitral valve. Using these images, we can generate 3-dimensional beating heart models of that patient, looking at the size, shape, and function of each chamber, and deliver 30,000 data points describing that individual patient's heart. We can also generate 3-dimensional models of the blood vessels that deliver blood to and away from the heart. But we can also measure damage to the heart muscle using MRI, as well as accumulation of abnormal proteins or iron. On the left, you see an illustration of a sudden blockage to one of the heart arteries. This causing a heart attack with damage to the front wall of the heart. By placing this patient in an MRI scanner, we see that we can highlight the damage using a variety of techniques. In the images that you see in the middle, the normal heart muscle is black and the white indicates irreversible damage that's been caused by the heart attack on the heart muscle. We're also able to show this in 3 dimensions, as you can see on the right, along with the coronary arteries, showing exactly where the blood vessel is blocked and the downstream effects of the heart attack. We can also measure blood flow using MRI. Blood flowing into the heart muscle, as shown in the top middle image, where there's reduced blood flow from a blocked artery into the muscle. We can also see the blood flow coming through the heart valves in the image below, where we colorized it to make it easy to see blood coming towards us or away from us. Or traveling throughout the entire chest using 4-dimensional imaging, as you shown on the right, where we can see all the blood rushing through the heart chambers, through the valves, and through the blood vessels simultaneously. Now, I want you to appreciate that these are not just images, they're representations of tens of thousands of data points that can be used to describe who you are and what diseases are affecting you. So when we combine all this information together, you start to appreciate that from a single test, taking between 30 and 60 minutes, we can gather a tremendous amount of information that can be used to deliver personalized predictions about you as an individual. So how do we use all this data today? Well, they are considered images that are put on a screen that a doctor looks at. We make an opinion, and we then dictate lines of text that summarize that opinion. That's pretty much it. So this text report is sent to the electronic medical record and to your doctor to decide what to do with that opinion. Now, maybe that's not optimal. How could we do things differently? What if we were to extract all the information behind those images, organize it for each and every patient, how each chamber moves, the valves, how the muscle is damaged, you get the picture. What if we simultaneously did the same thing to understand who the patient is that those images are from? Ask the patient, who are you? How are you feeling today? What other illnesses and medications do you take? What was your recent blood work? If we start to do this, you start to realize that we've created a highly standardized set of features that are routinely captured, just like a fingerprint, a pattern of data that describes a unique individual patient's cardiovascular health. So we can start to think that this is a data set that maybe a mathematician or data scientist might like to look at to identify patterns. And that's exactly what we're doing at the Stephenson Center. We're using standardized sets of features that we collect in each and every patient referred to our center to build what you can call patient health recognition algorithms. This is exactly the same approach as what you've all experienced to date in the form of facial recognition, the ability of artificial intelligence to recognize you as a unique individual from your facial features. So my research focuses on how these same techniques that we trust to unlock our personal devices can assist physicians and their patients to make better health decisions. So how is this done? First, you need a lot of data. Today, we've engaged over 20,000 diagnostic visits for cardiac MRI and CT at Alberta Health Services, asking patients to allow us to convert their test images into a data map and answer a standardized set of health questions at the time of the visit. We've then worked in partnership with Alberta Health Services to match their laboratory and pharmacy data, as well as track clinical outcomes, and put this all together into an anonymous data vault. So this anonymous data sits with a standardized set of features and what's happened to the patient. Then using techniques called machine learning, which is just the process of teaching a machine how to solve problems, we can develop algorithms to train to do different tasks, identify what is this disease, or what's going to happen to a patient, and to get better over time with experience in making those predictions. Now, to gain enough experience, you need a lot of data. And once you feel that you've identified enough patterns in that data to make a prediction, you then have to validate it. And what we do is we look at a completely separate set of data that model has never seen before and see how it performs. If it performs well, we can then implement it to help answer questions like, what's my diagnosis, or what's my prognosis with a certain treatment? So let's take a look at some examples. We recently published this study in Frontiers in Cardiovascular Medicine. We trained a neural network, which is a type of machine learning, to diagnose the cause of heart disease from MRI images. And this was in patients with thickened hearts or hypertrophied hearts. We used a novel approach developed at our laboratory to model the three-dimensional shape and patterns of muscle fiber contraction from the MRI images. By developing a virtual 3D beating heart model, we extracted over 30,000 data points per heart as it moves through its contraction and relaxation. And then using a neural network, we're able to train an algorithm to automatically diagnose what disease that is with 94% accuracy without any user interaction. This is now used to identify patients with genetic heart disease, like in this case, hypertrophic cardiomyopathy, but we've also trained other models to diagnose ischemic heart disease or dilated cardiomyopathy. And this is work that we're doing with the Alberta Machine Intelligence Institute. Now, in this example, we trained an algorithm to predict the future occurrence of atrial fibrillation, or AFib. AFib is a common heart rhythm that affects about 6 to 8% of the population over 50 and annually costs over $26 billion in North America. And this is in part due to a 5-fold higher risk of stroke because the blood isn't cleared from the top chambers of the heart. Unfortunately, many patients present with stroke. They don't know they've got this. So using data from over 7,000 patients, we developed an AI algorithm to automatically estimate a patient's probability of developing atrial fibrillation over the next 1, 2, or 3 years. Our algorithm does this with 85% accuracy, which is 20% higher accuracy than any prior model. We're now working towards being able to bring these estimates into our routine reporting for every test. Next, we've trained a model to predict heart failure admission. Heart failure is the inability to breathe well or have fluid accumulate in your lower extremities due to inadequate heart function. While dropping quality of life in patients, it's also a massive cost burden to the healthcare system, each admission costing an average of $15,000 up to $20,000. If we can predict who's going to have this admission, we can monitor them, put them into the heart failure clinic and prevent this from occurring. So similar to AFib, we combined the imaging and health information from each patient to build a risk algorithm. And this model classifies patients as either high or low risk high-risk patients having a 4.2-fold higher risk of heart failure admission, and we can predict if they're going to have an admission by 1 year with 84% accuracy. So we can now identify patients and send them for surveillance so we prevent them from coming back to hospital. Now, my final goal is really to address the most devastating of heart-related problems, sudden cardiac death. Unfortunately, almost 500,000 people each year suffer from sudden cardiac death. And we're working to build an AI algorithm that can predict this before it ever happens. The most challenging of tasks we face, though, we're drawing on multiple types of data, not just imaging, but also laboratory blood work and electrocardiograms, bringing it together. And we think that we can develop an early warning system that if we find a patient that hits a high-risk criteria, we can refer them for an implantable defibrillator that is life-saving. Leveraging grants from the Canadian Institutes of Health Research, the National Institutes of Health, and support from our philanthropic community, we believe this is achievable. We currently have analyzed over 1,000 patients with ischemic cardiomyopathy, dilated cardiomyopathy, and 2,500 patients with hypertrophic cardiomyopathy. And so in summary, we formed the CIROC registry in 2015 at the Stephenson Centre using a seed investment from the Calgary Health Foundation. With this, we've developed one of the richest data repositories in the world surrounding patients with cardiovascular disease. And based on this success, the Libin Cardiovascular Institute is now engaging in an effort to expand this paradigm across cardiovascular care in the Calgary region. This being assisted by concurrent efforts of Alberta Health Services to revamp the electronic health record system. As co-chair of the Libin Data Initiative, I'm helping to migrate the lessons of the CIROC registry to deliver at-scale solutions across cardiovascular care and to establish an unprecedented framework for delivering personalized cardiovascular care at Alberta Health Services. And this really could not have been achieved without the support of Alberta Health Services and the Calgary Health Foundation. And therefore, I'd like to reiterate the sincere gratitude of the cardiac care team and the research program for the ongoing generosity of the philanthropic community and Calgary Health Foundation for making these really ambitious goals a reality. Thank you.
Thank you, Dr. White. What an incredible presentation. Thank you for taking the time for that. 15 years of innovation in care and research is going a long way for our community. It's just impressive how, all that data can come together to provide, personalized and even predictive care, as you talked about, being able to sort of get upstream and give people the care and preventative measures that will help them to avoid some of these cardiac events. So thank you very much for that wonderful presentation. It's a privilege in our organization to get to meet so many people whose lives have been transformed by the incredible care delivered right here in our city. I'd like to welcome Joe Horler, who has agreed to share his story of gratitude. Welcome, Joe.
Thank you, Mike.
Yeah. Hey, Joe, just to start with, could you tell me a little bit about yourself and what life was like before you had your cardiac event?
Well, first of all, let me just say how impressed I was listening to Dr. White. We've only met on the pre-Zoom session, and I was really impressed to read of the research work he's undertaking. Really meaningful. I'm a native Calgarian. Family, great-grandparents settled in Alberta in 1884. So along with that, I've most of my life worked in the energy sector for 32, 34 years. I retired in 2006 to spend more time doing some of the things I like, traveling, hiking, getting out with a camera, which has been a passion of my wife's, and it's rubbing off on me as well. And I still was playing old-timer hockey, trying to stay, I wouldn't say fit, but active. The picture you see there is of me in the Dingle Peninsula in Ireland in late 2019. And it was actually on that trip where I first got a real sense that I had a problem. We'd done a long hike, and at the end of that hike, our guide decided we should go another kilometer or two uphill through woods. And on that, I was carrying a backpack with a camera. I got sharp pains in my upper left chest and just simply ran out of gas and had to stop. And then about 3 weeks later, my wife and I were on a photo workshop in Yellowstone, taking pictures of the wildlife there. And we ended up on a long slog over deadfall and trees in search of a gray owl, which I know this sounds a little arcane, but it was to be a special photograph, and it was raining, and I was carrying about 20-pound backpack and camera gear and a tripod, and I fell behind everybody else very quickly. And it told me I had a problem and there was something going on. So when I returned to Calgary, I sought out my family doctor and felt we should do my annual medical and see what that told us.
Wow, that's thank you for recounting that story of some of those early events that gave you a hint. Can you say a little bit about, you know, you obviously got the care from your doctor, and he would have talked to you a little bit about the recommended treatment, and you were told you needed double bypass surgery.
Where it came about is the process went, my doctor sent me to Mayfair Diagnostics for myocardial perfusion imaging test, and under stress load, it indicated that I had a problem. That led to an angiogram at Foothills. And I can still remember at the completion of the angiogram, which to my mind went very well, the cardiologist came and said to me, well, you know, I would have liked to have fixed you with a stent, but unfortunately you have a blockage, and it's going to be one that requires open heart surgery. And I was literally shocked, very much so. And a few minutes later, I spoke with Dr. Holloway, one of the cardiac surgeons, who said he felt I was a good candidate for a double bypass and would present my case to the cardiac surgery team. So that happened basically in mid-December of 2019. The next step in the process was we met with the man who was determined to be my surgeon, Dr. Mohammed Hassan, who was simply wonderful. We met with him in late January. And this is important. He didn't just talk to me. He talked to me, but he talked to my wife as well. And he treated us really as friends as well as his patient, and indicated what the process would be, how he was going to do the surgery, and really gave us a lot of comfort that being at Foothills was going to be truly a lifesaver for me. So that was wonderful. And then of course, COVID arrived and everything got put on the back burner for an extended period of time. Through that period, I ended up in discussions with the cardiac team at Foothills, and was given comfort that no, I wasn't lost in the system, because I wasn't deemed as being absolutely critical, but I was semi-urgent and would be fitted in when there was an opportunity. So they kept in touch, and they talked to me and they told me, no, we haven't lost you. You are on the list, and you'll move up when surgeries start again. And then we got a call in mid-July basically saying, you're due in here in 8 days, and Dr. Hassan will be doing your surgery. So that's how it played out, Mike.
Yeah, thank you for those details. You mentioned COVID and just the, you know, the time that it was, a lot of stress in the system and some uncertainty, obviously, with your surgery time. How was your care? I mean, so you finally went in, and it was still during a time of COVID. How was your care overall, surgery and post-surgery, and what do you have to say about Dr. Hassan and his work?
Well, you know, I had not been in a hospital for years. So I can only say it was, to use the word, outstanding. It was really tremendous. I went in at 9 o'clock on a Thursday morning, and I had the surgery that afternoon. I don't remember much then till I woke up in the intensive care unit at about 3 in the morning with the ventilator in. And the young nurse there introduced himself to me and said, I'm taking care of you here in the ICU. And first thing we're going to do is try and get you off this ventilator in the next little while. And so he communicated extremely effectively with me and settled me down. as I was, like most people, when you wake up and you don't know quite what's going on. He relaxed me. We got the ventilator out about an hour and a half later, and all my vital signs returned to normal very quickly, which was lucky. And by 11 o'clock that morning, I actually walked out of the ICU over to the cardiac unit for the next stage of my care, where I was one of a group of 4 patients under very close watch, but not one-on-one as I was in the ICU. And again, the nursing team, the doctors who looked at me were tremendous. I had a meeting with Dr. Hassan. He stopped by to tell me that he told me I had really tough bone structure and had a heck of a time opening up my chest cavity to do the surgery, which we both laughed. It made me feel good. And I just felt like I was making real progress. And so I was there in total 4 days. So I walked to the ICU. I got busy walking up and down the halls with nursing support. I had to do the stair test, walking up and down the stairs to prove I was ready to go home. And by the following Monday afternoon, I was discharged and went home. It was an outstanding experience with wonderful people, from the surgeons to the follow-up doctors and to the nursing team that took care of me.
That's great, Joe. It sounds like you've had exceptional care, and I know since the time of your care, you've reached out to the Calgary Health Foundation and have given back and helped support cardiac, as well as the COVID response that we've been working on. Why did you and your wife choose to give back and support healthcare in the community?
Well, it was, obviously it was something very tangible for me. I'd experienced tremendous care at the hospital and probably extended my life a long time because of it. So that was number one. 2, we were lucky enough to be in a position where I'd had a very successful career and we were able to make a larger than normal donation, and we wanted to direct it there, both into the research side so that other people can benefit from cardiac research along the lines of what Dr. White is talking about, and also though to the frontline workers, because I think very few of us don't get a chance to be in the hospital under these circumstances, and to see firsthand the dedication of the people at Foothills and how hard they're working. It just meant a lot to us, and we wanted to thank them and put it into sort of the operating area of the hospital. I'm not looking for a door in my name or an edifice or anything like that. I want those people who are on the front lines to also benefit from our donation and be able to continue their great work.
It's so nice to hear stories like yours of people giving back and just showing gratitude, but also trying to pay it forward, right? To improve the system down the road by investing in such things as research. And we heard, of course, from Dr. White today and how that happens and helps to improve care. Can you tell us a little bit, Joe, about what life is like now, having faced this health challenge, and now that you're through the woods?
Well, I think I've taken on the rehab side of it very effectively. We've been walking a lot. Even still through winter, we get out and walk. Near where I live in the Altadore area, there's the Glenmore outdoor track. And I found that one of the things I do is I walk over there from my home, which is about 6 or 7 blocks. And then I can do circuits around the track and get that exercise that I need, because of course, the follow-up would have normally put me at Repsol Center with total cardiology. And of course, that wasn't available anymore because of COVID again.
Right.
So we've been walking a lot, and we take our cameras with us when we go out. We take pictures. And one other thing we do, Mike, I'll tell you, for those of you who have watched Netflix and the Queen's Gambit, my wife and I play chess every day. We have an ongoing chess match that's been going on for probably over 15 years now. She always wins every year, I have to say. But it's a great thing that we do together and keeps us working on things as a team. So it's great.
Oh, well, that's wonderful. It sounds like you have a very rich quality of life, and just wanted to say thank you, Joe, for your donation and also sharing your story with us. That's exceptional.
Treat for me to be here. Thank you.
Yeah, thank you. I would now like to open the floor to questions. We will have around 10 minutes to answer questions, and any questions that are not able to be answered today, we'll just let you know that we'll send them out along with the email that includes the video recording from today. So Valerie, can you please read out the first question for us?
Thanks, Mike, and great to hear the real impact it's having for people like Joe. So thanks for sharing your story, Joe. The first question's for Dr. White. You mentioned some detection work you're doing, particularly in people that have maybe hereditary risk factors for certain cardiovascular diseases, but how early can people with some of these known factors benefit from some of the research that you're doing, and how does that work in terms of their conversations, I guess, with their physician?
Yeah, thanks, Val. So one of the things that is particularly challenging for the work that we do is picking up the disease at the right time in the right patient. So very often we can detect disease that occurs at its later stages. And sometimes we're effective, like in Joe's case, of being able to address problems very effectively, but sometimes we can't. And so one of the efforts that we're making is trying to make predictions as upstream as possible so that there's as much headway or lead time that we can intervene and prevent rather than treat disease. And so there's a number of strategies that we're taking to do that. Number one is that we're looking for very much more sensitive tools to be able to pick up even just very subtle changes that occur, for example, in genetic heart diseases. And so one of the studies that we're looking at right now, which is in 2,500 patients with hypertrophic cardiomyopathy, and this is leveraging data that was collected at 44 hospitals around the globe as part of a registry. And what we're doing is trying to find early markers that can pick up genetic abnormalities, even in patients that their hearts look really quite normal. And so by doing things like this, which is really training algorithms that from images, we can actually try to identify what their predisposing factors are, like genetics. We may be able to have early warning systems and pick up patients with very, very early stages of disease. Another example is that we're going to be working with a national team looking at a disease called cardiac amyloid. And this is a disease that until recently there were very few treatments for, but now there's some new drugs that seem to be able to reverse the disease, but only if we catch it at a very early stage. And so we're going to be working again with a national initiative to be able to build artificial intelligence tools to pick it up at the most earliest of stages so that that care can be implemented. So those are just a couple of examples, but I very much appreciate that we do need to focus on early stage disease and even prevention of disease from the beginning rather than waiting for it to occur.
Yeah, thank you. And just to build on that, is there any work that you're doing, I guess, in a multidisciplinary approach with other specialties to inform care? Often, obviously, people don't just have one thing or another, but how is this kind of informing some of those other care areas?
Yeah, that's a great question. And one of the, I think the most obvious example I can use is that we've been in Calgary developing a surveillance program for cancer patients. It's not well known that almost 20 to 24% of patients that are receiving chemotherapy for either breast cancer or lymphoma develop heart disease from the actual chemotherapy itself. And so the chemotherapy does a very good job of killing the cancer, but unfortunately damages the heart in the process in a large number of patients. And so you trade one disease for another. And so we've been working with the oncology team to develop a program that they can refer their patients to our MRI program for surveillance. So we do imaging before they even get their first dose of chemotherapy. And then we scan them at 3-month intervals during their chemotherapy. And the research that we're doing right now, which is being led by one of my PhD students, is showing that we can detect very, very early signs of heart damage before other tests can find it. But more importantly, we're detecting signature patterns that even before they get their first dose of chemotherapy, we can identify patients that are going to be at higher risk of being sensitive to the chemotherapy and developing toxicity. So that's complete prevention before they've even been exposed to the treatment. So because of this, we're working with the oncology teams and the cardio-oncology program to actually develop better care strategies or care pathways.
That's great. It's a good example. It actually leads to another one of the questions here, and that was, are you able to detect, earlier detect some impacts of various medications or drugs on kind of heart disease or people that shouldn't be on certain medications as well due to the impacts it could have for cardiovascular health? Yeah,
one of the interesting things, and again, it comes from this historical use of guideline practice care. As we tend to say these are all the medications because you're a heart disease patient, and the clinical trials have shown that you should be on this and this and this, and so you end up on 5 or 6 medications. And not many efforts have been placed on saying, do you really get benefit from all of those as a unique individual? And so one of the things that we do have the potential for with the data set that we've collected is that we've got all the pharmacy records as well for each patient that we can draw on. And so over the course of care, we can see when doses were adjusted, what types of combinations of medications, and in the context of each individual's health profile and disease. And so one of the things we'd like to pursue in the future, if we can expand our team, is to try to understand which medications and combinations of medications are actually providing benefit. And this is with a strategy of trying to prevent side effects, prevent complications from medications that are really being given potentially without much benefit for some patients. And so this is all about improving the precision of the care that we deliver.
Great. Another question that's come in is one of the things we're hearing is that women seem to have a higher rate of hypertension, maybe be at higher risk for certain cardiovascular disease. Are you doing any gender studies to either validate that, or have you validated that and furthered the research on the differences between how it shows up in men and women?
Yeah, absolutely. It's a very interesting topic and very important. And one of the, we just recently published a study looking at how in women, this was in a study of around 3,800 individuals, and we looked at women versus men and what their risk of having heart attacks and needing to come back for bypass surgery was. By looking at the influence of blood pressure and on how thick the heart muscle becomes in response to high blood pressure. And so it's right on that topic. And what we found was very interesting, that women that are exposed to high blood pressure actually develop different changes in their heart than men do. The type of thickening of the heart muscle that they get is different. And what ended up happening was that the women did much worse than men for the same amount of high blood pressure and all other factors. And we feel that that's likely a sex-related change in how the heart responds to pressure load, which is high blood pressure. And so that study was very enlightening and actually has changed our approach to how we do risk modeling in that patient group, the one that's we're looking for coronary artery disease related complications. But another one I'll just briefly mention is that we've recently found that women are having poorer response to treatments for atrial fibrillation. And so using our registry data, we're able to identify that women that have been referred for ablation to get rid of atrial fibrillation were doing worse than men. And this has actually been described in other centers as well. But what we're now trying to look into is, what is it about women and their hearts that is different than men, that is causing this difference? Is it something structural? Is it something about the way that the heart is changing over time? We don't know yet, but we're hoping to be able to figure out some of these sex and gender related issues.
It's very interesting. I just have two more questions. Those are the last one for Dr. White. One of the examples you showed was a 28-year-old male with a viral infection having some implications on his heart. Can you maybe talk a little bit about any involvement you've had with understanding further the long-term impacts of COVID, and obviously the world we live in today?
Yeah, so unfortunately, we do know that COVID does influence the heart, and there's been studies that have been published already showing that at around 3 months following infection, there's about 20 to 25% of patients that will still show residual injury in some form of the heart muscle, even if they didn't present with a heart complication. And we don't know the long-term effects of that yet, but I'm part of a provincial team that we got CIHR funding. It was led by Dr. Ian Patterson in Edmonton, and there's 2 sites, our site in Edmonton, that are studying patients that have had COVID infection. And we're going to be starting to do those scans in about 6 weeks, actually, at the Stephenson Centre. And so any patient that's had a positive COVID test within 90 days will be eligible for this study. And we're going to be scanning with the MRI their heart, their brain, their lungs, and their liver. And we're trying to best understand what the impact of COVID is on these organs, but also track these patients long-term to see if there's any adverse outcomes. We have had some very severe cases, one of which we recently published in the Canadian Journal of Cardiology, where we were able to successfully treat a 62-year-old woman that had devastating inflammation of her heart. It was very weak and hardly beating. But with aggressive care, we were able to return her heart function within a short period of time to almost near normal levels. So what we know is that while we can see injury to the heart muscle, we also can effectively treat it. But I think that the focus is going to turn to what are the long-term implications of going through this type of viral inflammation and injury.
Wow, it sounds like there's just there's lots of questions around what's even possible. It sounds like the research that you're doing kind of opens the door for so much more to be understood, which is really exciting. The last question is actually for Joe. Joe, you mentioned that one important piece in your care was actually involving your wife in the conversations. Can you just maybe comment a little bit about how important that family integrated approach and that support structure, informing your wife, making sure she was involved in your care, was for your case?
I think it was very important. Obviously, I can tell you that when I shared with my wife, actually from the angiogram theater, that in fact they could not put a stent in, and I was now going to be prospectively scheduled for open heart surgery. If you think I was shocked, she was really shocked, because she was at home and got this email from me indicating what my situation was. So then we sort of moved forward together in this, and of course it did change our life, because we were cautioned a lot about overexertion, exercise, and it was the middle of winter, and there's things to be done like shoveling snow and things like that as part of your normal life pattern. And my wife actually had a photography trip planned that she had to cancel, because certainly our family doctor didn't feel it was appropriate for me to be home alone for 2 weeks following my diagnosis. So when we finally did get a chance to meet with Dr. Hassan, the comfort he gave us about, he said to me, Joe, Diana, we could put a stent in, but he said, I'm going to hold your heart in my hands and I'm going to look at it. I'm going to study it. I'm going to also know if there's any other problems or that. And then I'm going to fix your problem. You've got good veins. He checked my leg and he said, we'll be able to do this double bypass very easily. And when you're finished, you're going to be like a new man. You'll be back walking, hiking, playing golf, doing the things you like. And we're going to set you up for the rest of your life. He gave us a lot of comfort and it eased both of our stress levels. So it was tremendous that way. And it was his caring approach that meant an awful lot to us.
That's wonderful. I think that the family approach that really has been the focus of healthcare, really, as you articulated, we don't appreciate maybe the stress on our significant others or our family during the crisis. So it's so great to hear that you were supported. With that, Mike, I'll turn it over to you.
Thanks, Val. First of all, I just really want to thank everyone who joined us for this webinar today. Very grateful for you making the time for this, and I hope you've learned lots. Also wanted to give a special thank you to the speakers, Dr. White and Joe. Thank you so much for your time today. It's just been fascinating to learn more about the Stephenson Cardiac Centre and your personal experience, Joe. As I mentioned earlier, this event has been recorded and we will be following up the event with an email that will have a recording of this event, and we'll also include the answers to any of the questions that we weren't able to address. So we'll sort of put those together and send those out to you at the same time. Donor support is just exceptional. It allows us to make breakthroughs like what we've talked about today at the Stephenson Cardiac Imaging Centre. And I'd really just like to thank everyone for their ongoing support, and thank you all for joining us today. Have a great day.